3, 2, 1.
Again, welcome back to this afternoon's Hypopara sessions, or welcome if this is your first time online with us. Just a reminder of housekeeping notes. Your audio buttons are mute, but you can ask questions using your chat button. And finally, please visit the auction site under the Teams button. Our bidding will close 30 minutes after our final session this afternoon. And now I take pleasure in introducing Dr. Blaine Everson, who is presenting on caregiving and emotional well-being, which is so important for not only our patients, but for the families who take care of our hypopara patients. Dr. Blaine is a licensed marriage and family therapist in private practice in Athens, Georgia, where he has been a clinical director with the Samaritan Counseling Center since 2007. Previously, he worked for 6 years at the Fraser Center in Hinesville, Georgia, near a major military base. His practice history includes extensive work with military families and readjustment issues associated with military service, along with special interest in the recovery from emotional trauma at the familiar level. He recently co-authored and edited Families Under Fire, Systematic Therapy with Military Families with Charles Figley, and it was published in 2010 with Dr. Rulish. And I had the personal opportunity to read his book. So if you get a chance, please read it. But without further ado, I introduce Dr. Everson.
Thank you very much, Loretta, for that wonderful introduction. I didn't realize I had done all those things. I am here today to talk about caregiving and emotional well-being in loved ones of patients with hypoparathyroidism, and I'm also interested in since a number of cases of hypoparathyroidism can be acquired through surgery or through through other medical treatment related to thyroid cancer. I also include that as well, as to not exclude anybody. So we got about 45 minutes today, so I want to make sure that I get through most of everything. I'm really happy to be back. I've done this, I think this is my 5th time doing it. I missed several years. One of the things that I've become more and more interested in as time has gone on is working with families of people families who have members who are ill and have chronic illness, such as Parkinson's disease is one of the has been a focus of my clinical practice. Recovery from major heart condition, open heart surgery, things like that. I got into parathyroidism and the interest in research related to that as a result of being contacted initially by Jim Sanders a number of years back, and he was interested in having me talk a little bit about what patients could do to improve their quality of life, which I'll actually be talking about at which is really funny. It was I was raring to go today at about 12:45, and I realized it was Pacific time rather than Eastern Standard Time, so it would have been about 9:45 all of your time if you're on Pacific time. So anyway, I'm just happy to be here, and I'm glad that we can talk about this. One of the things that we find that when I see people come in my office, and I also wanted to say before we get started too far, is that this has been the coolest experience, because actually, since I didn't get a chance to go ahead and do my talk earlier, I decided to go and trim hedges. So I've never done that during a conference. So that's been kind of this whole virtual thing due to COVID has been a very interesting experience in a couple of the conferences that I've attended over the past couple of months, and a couple of ones that I've spoken at. So it's been we're going to see how well this goes. One of the things that I really find that's a big issue with families and caregivers is the emotional and behavioral symptoms associated with their loved one who actually has the condition, who actually has hypoparathyroidism. I'm not going to get into all the hypocalcemia and the effects that that has, and the lack of metabolization, I guess, would be I was reading a study the other day that had come out a year or so ago, and they kept using that. I think that was the way you pronounce that word. I have only a PhD. I don't have the MD, so I only use $5 words instead of $10 words. One of the things that that you may notice in your loved one is that there may be some irritability. There may be some agitation and fatigue. And one of the things, and if I had to put a and if I had to kind of put a bracket around those three, I would say it was they would be a bigger there would be a bigger factor known as frustration, just the difficulty sometimes associated with not feeling well for several days and then feeling okay for a couple of days. And so it's kind of an up and down thing based on the how well controlled this is, especially during the first stage or during the first stages of the diagnosis, and then the early part of treatment as they're getting into, and they're as the patient and the caregiver are kind of getting adjusted and adapted to living with that particular condition. There's some confusion sometimes related. Brain fog is kind of a common term that we use, and brain fog is just kind of a whole syndrome of symptoms that are and it's common a lot of times. It's one of the neurological signs of various conditions. Very common, as I mentioned earlier, related to Parkinson's patients and patients with neurological disorders or chronic neurological disorders. With that, memory problems, lack of concentrations, not being able to remember. A couple of my hypoparathyroid patients that I've begun to work with over the past number of years, because I got interested in this, and so the physicians and the nurse practitioners that I work with consequently kind of got interested in this as well. So they had to kind of go to school and do some homework on this. But one of the things we find is that not being able to remember whether you did something or not, or where you put things, is incredibly frustrating, and can certainly, or just kind of being in a situation where you were preoccupied with something else and you're not able to concentrate on particular things at the time that you're at the time of your at the time you're doing them. I should say that. There's some dysphoria along with mood issues, sadness that comes incumbent with that. Sometimes after this goes on and there's difficulty, the more difficulty with manageability we have, the more hopelessness and sadness and helplessness you may feel. And then there are also the physical aspects of it. I've got muscle tingling and numbing, physical pain. Tetany is not uncommon with this particular condition, especially in the early phases. Or there was some issues last summer in 2019 or earlier, and that was talked about quite a bit at the last conference with the withdrawal of, they had some problems with the delivery system for Natpara, which was almost, from what I understood and from what I had been told by clients, was a godsend in terms of constant delivery of parathyroid hormone. So anyway, I just want to kind of say that and talk through this. And go to the next slide. So we've already done that one, so I'm going to pull this one over. One of the things that you run into is, I don't think that people, one of the great things about working with physicians or psychiatrists has been that they tend to focus a great deal on they tend to focus a great deal on severity, and you can't always cure something. For example, other physicians can cure things with surgery. Other physicians may be able to cure things, with certain medications, and it's a transient, it's like the flu, or like certain certain bacterial infections. I mean, they can give you medication, it goes goes away after a certain period of time. But with psychiatric conditions, for example, and a lot of these are comorbid with chronic illness, any kind of chronic illness, much less hypoparathyroidism per se. They look at severity, and they look at severity indices. What I mean by that is that if you're suffering from something at a severe level, when you come into treatment, but they can get you down, or we can get you down to a moderate to mild level of symptoms, what we find is that vastly improves people's quality of life, and it also improves their sense of well-being. So interestingly enough, that's, if you can do that, you can actually make a I have a friend of mine who's a psychiatrist. He calls it making a dent. You can actually make a dent in some of the symptoms, and you can make things better for both the patient and their families, not only in the short term but in the long term as well. To the extent that the patient suffers from the symptoms long enough and severely enough, the people around them may find that they become traumatized by this experience. Not only does the patient become traumatized by the illness, and this is one of the things that we're really you're starting to see more research come out of medical family therapy, medical social work, people starting to take a real hard look at the fact that chronic stress in and of itself can have a traumatizing effect. When we talk about, it's not just the exposure to the event. When we talk about interpersonal trauma, we're talking about the exposure to the person who's been exposed to the event, or perhaps a combination of both. So when we're talking about trauma that results from the physical, cognitive, and emotional aspects of the traumatized family dynamic, the entire system can become traumatized to some extent. And here again, these vary by degree. So I refer to these as meta-traumatic experiences, and don't steal my word because that's my term. I haven't published it yet, but meta in the sense that it encompasses a wide variety of people, interactions, and events as we go through life. I wish I had time to maybe next time I can do 3 presentations. I don't want to hog up all the time, but I would like to do one of the major theories that we use in family therapy and to train therapists in general is called the lifespan development theory. And what we look at is instead of taking, everybody's familiar with the developmental psychologists like Jean Piaget, Erik Erikson, Freud, being some of these folks. As individuals are born, go through early childhood, go through middle, late childhood, go through adolescence, become young adults, become middle-aged adults, become older adults, and eventually shuffle off this mortal coil, as Shakespeare put it. They go through changes, and the people around them go through changes, and they're both affected and affect the systems around that they inhabit around them, whether they're family systems, work systems, community systems. So one of the things, so not only are do the individuals go through those changes, Families go through those as well. So there is a family lifespan approach that we go through and talk about when we train. One of the things we talk about very early with trainees is you have to figure out what phase of life or what stage of life or family development the family is in when they come in to see you. And for people like me, there are a lot of therapists will just see you by yourself, or they. But when we talk about people who are trained systemically, and people who practice marriage and family therapy, especially, we typically see more than one person in the room at the same time. If if you want individual therapy, I can certainly do that. But there are a lot of people around who will, I have a very good friend of mine who she brews a pot of tea for her clients. And I usually have, 6-year-olds trying to break stuff in my office, or they would spill the tea, and we might have some liability on our hands if they did. So I'm usually in the room with several people at a time at the same time. I would certainly see the patient and the caregiver. And a lot of times, if with terminal, and I've seen a number of cancer patients it was terminal, and after they passed away, I would continue to see the caregiver or their spouse, whatever the case was, after that. And sometimes I would pick up another family member with that person. So I'm fairly adept at looking at things, not only from not just from an individual level, but from a level of from a level of the couple. Or I rarely ever see a teenager, for example, if the teenager hasn't, if I don't see a parent with them. I honestly rarely ever, I see couples sometimes, but I also will see other family members with them, because there's nothing like a couple who's having trouble for whatever reason. Let's say they're having marital problems because one member is ill or chronically ill. Nothing like a 12-year-old to come in and tell the truth about everything, and kind of get down to the nitty-gritty. So it's always a pleasant experience. I find that I get more done more quickly the more people I tend to have in the room, and that's always a judgment call as well. So I'm going to move on over to the next slide. One of the things that I was setting that up, kind of talking about family development, and and stages of family development, because trauma disrupts that. Finding out that you're ill, finding out that you're go take it back to the military example. Finding that your spouse is going to be deployed to a war zone within 3 months. A lot of things disrupt the normal life cycle development. So one of the things that we run into is that once the patient one of the things we run into quite frequently is once the patient becomes ill, they become preoccupied with that illness, and as they should. They become preoccupied with either, and it is almost, a lot of you are familiar with Elizabeth Kubler-Ross's work of the stages of grief and stages of dying. There are stages of acceptance of illness. My life has changed now because I just realized that I'm ill, or I've become ill. There's some coming to grips with that. There is some grief. There is some anger. There is that sense of loss of related to previous functioning. So when we think about this from a psychoanalytic standpoint, if you have we've all lived with abandonment at various stages of our lives, from clinically, whether you've had somebody leave you, whether you've left somebody, and had dealt with those emotions afterwards. But there's a concept called proximal abandonment, and it's the way people are physically present but they're emotionally unavailable. And this is different from what we call it the ambiguity of loss. I mean, there are, you're there but you're not there, and you seem okay at times. And this is one of the things with people that I run across with people who have endocrine disorders, who have there may or may not be as many visible signs or outward signs. Cancer patients, sometimes they seem okay. People don't know that they're necessarily ill until, for example, they're in stage 4, and it's and they're not, and things aren't turning around. So, but the but ambiguous loss would be you're physically absent, but could be psychologically present. In that case, there may be a separation, and one of the things that we've seen a lot is that especially with COVID-19 and with the outbreak that we've been dealing with over the past number of months, is that we've had some issues with grief because people are not necessarily allowed to be with their families during their hospital stays, and in some cases, those family members have passed away as a result of as a result of COVID, and people just don't know how to react to that. So that's been a tough situation for a lot of people. But that's an ambiguous form of loss. This is different. You're still there. Proximal abandonment, you're still there, but you're not there emotionally. You're there physically. One of the best example of proximal abandonment that I use in teaching is alcoholism versus drug addiction. For example, if you're a heroin addict, or if you're a really bad illicit drug addict, you don't function well typically. Alcoholics can a lot of times still function very well when they have to face the public, when they're front facing, as it were. When they're not, when they don't have to, then they don't, they may not do so well, and there may be some issues related to that. So that would be the parallel that I would draw of sometimes a physical presence but emotionally unavailable. And what this does is it gives us this notion, or it kind of leaves us with this notion of, and this is another thing I've kind of discussed over the years, of the idea of insidious trauma versus incendiary. Those are, and that actually was in my was in Families Under Fire. We talked about insidious trauma. Rather, it's the little things that just add up. And nothing, there are no incendiary events. There's no car crash. There's no train wreck. There's no plane crash. There's no fire, flood, tornado, hurricane, anything. There's more of it's almost that everyday stuff that doesn't necessarily, people may or may not, somebody who didn't understand what was going on may or may not look at that. Well, God, I don't know. I don't know why this is affecting you like it is, and so it's those kinds of things that people don't quite realize, that it's not evident, that you didn't have a car accident, you weren't wounded in war, you weren't, you didn't suffer, you didn't live through a hurricane, those kinds. It's not that. It's not that kind of traumatic experience. It's more it's more of a subtle traumatic experience, and people, a lot of people just don't understand it. But these things, but these events are, and it's the little things. It's the setbacks in treatment. It's the diet. It's a bad, well, let's just say setbacks in treatment. That could be a primary example of that. Or the patient, for example, gets tired. The caregiver gets frustrated and angry. The patient gets tired of living a certain way day in and day out and having to take treatments that may or may not be comfortable always. So. But the two things that I want to point out there would be the idea of coping. You do get an erosion of your coping skills. Most people cope pretty well with things on a day-to-day basis. And the other thing is lack of resource utilization. it's more difficult to cope if you don't have other people to rely on. It's other people. It's more easy to cope it's more difficult to cope if you don't have things that bring, that enrich you as well. Um, in your caregiving responsibilities. And it's always interesting. I have a couple of patients of mine who are actually professional caregivers. They go and spend time with elderly people, for example, who are or they contract with assisted livings. And so when I talk about caregiving, I do talk about professional caregiving, but this is not amateur caregiving. This is more when I talk about caregiving, I'm talking about it here more in a generic term. Nobody really pays you for this. Nobody hired you to do this. You do this because of the love and care you have for the person that you've lived with year in and year out, for, in a lot of cases, for the bulk of your lives. So one of the things a couple of things I do want you to be on the watch out for is that hopelessness in yourself. I mentioned it related to the patient who may be suffering from the condition here, hypoparathyroidism in this case. Decrease in pleasurable experiences, anxiety, depressive symptoms, a negative attitude, and that's not just towards the person. One of the things I have found is that people with chronic illnesses, they'll say, you're nice as all get out to me, but they'll tell the spouse or the loved one, they're like, but you treat everybody else like crap. I mean, you can catch yourself with me, but you treat our daughter, our adult daughter, or you treat you treat my sister, or you treat your sister like, you don't treat them very well. So be aware of those kinds of things as well. Loss of productivity, and I'm not just talking about work productivity. I'm talking about the inability to kind of to maintain your day-to-day life. Sometimes there are caregiving responsibilities that extend beyond what the actual patient needs. There may be family members who need care as well, especially if they're small children or teenagers. Loss of focus, that kind of goes with that loss of productivity. And self-doubt. People get discouraged. People feel like they're letting their loved one down. They don't care for their loved one, as something results in a sudden drop in levels, and ends up in a trip to the emergency room. There can be some guilt. There can be some remorse. Can I really do this? One of the things I don't talk about a lot, and I don't know if it's on a later slide, but it's the taking some respite every now and then, taking some time to do something for yourself, if it's nothing more than going to the library. And I know that's been more difficult to do. We have a huge library down just off of downtown where I live, and it's been closed since COVID. They just opened last month to allow only a certain number of people to come in. And one of the things I really enjoy doing is going and getting a book, and just a book that I would never really check out, but it might be something related to, something related to just an interest of mine that, I just read something and decided that, like fly fish, tying flies for fly fishing, there may be a book there that I found, and I just go read it for an afternoon or 30 minutes or an hour or two and just do that. But if you can get out and go places, where there's open space, that's always nice. Parks, botanical gardens, things like that. Just a walk around the block with somebody, sometimes other than the actual patient in some cases. So be very careful of this next thing that I'm talking about, pileup of stress. Pileup results from previously unresolved stressors and strains, and who can actually resolve a stressor when you're dealing with chronic illness, such as grief or loss related to previous life experiences. Not only did the patient's life change, your life changed a good bit as well. I like to tell the story of the lady a number of years ago, and this was one of those cases of just not having an awareness of kind of everyday, things that happened. She had a daughter who had cancer, very, very rare form of cancer, and was taking care of her. And the other daughter, who was a few years older, was she rode dressage and did show jumping, and fell and fractured two of her cervical vertebrae, almost died. So she had not only one child, but two children that she was caregiving for. And I don't know how she did it. She never saw anybody. She never, until afterward, they had gone back to school. The daughter had recovered. The daughter with cancer had recovered. The other daughter had, with the broken cervical, or the two fractured cervical vertebrae, had recovered. So a year later, she was, that had become her sense of purpose, and that become all the stuff that she had done for, over a year and a half. She's in my office, just kind of, just in tears, going, I don't know what's wrong with me. I don't, I should be the happiest person in the world. But here I sit in your office boohooing, and I'm just embarrassed about this. And I immediately looked at her and said she had PTSD, and at the time she saw me, she had seen two other therapists, and they had misdiagnosed her, one with anxiety and one with depression, but they didn't catch the PTSD. So I'm big into, I don't think every event, I mean, we really have, kind of, as we're 2 decades into the 21st century, we really have, there is this kind of victim, there is this victim mentality that we do experience, as almost as a society. And I'm not going to get into that, but the thing is that a lot of people who really are legitimately have been harmed, or who have been bothered by something, don't realize it. It's so that's the people people who have been obviously victimized, and their victimhood has been politicized, for example, to some extent. There's plenty of people to take care of those. I'm really more interested in the people who didn't even realize it a lot of times. So I just, that's always that was it's one of my most famous cases. She gets talked about a good bit, and was a really neat lady. But that was primarily what was going on. And she had, people call it common shock, but the truth is that it was just plain and simple post-traumatic stress disorder. She had a combination of an insidious event and an incendiary event that were traumatizing to her, and that she had to deal with both of them for fairly long periods of time. So it's this is not something that I take lightly. Is stressor pileup. This is one of the big things that we actually study, and in terms of in terms of family dynamics. One of the things that if you read any of my research, you'll actually see that I have, pileup of stress is a big thing for me, with regard to studying how families cope. With a variety of things, whether it be chronic illness, whether it be deployments, whether it be whether it be job loss, and sometimes those things will co-occur. And each new turn of the corner, or each new health crisis episode or other changes certainly can amplify the effects of pileup. And I don't really want people going online necessarily and trying to diagnose themselves, but there are some really good quality of life scales. One is the generalized contentment scale. Excellent scales, about 30 questions, 25, 30 questions. Another shorter one is just the satisfaction with life scale. It's 7 items, and you can find it. You can go and you can find them online, and they'll self-score in a lot of cases for you. I encourage people just to check in with them, just to check in with what's going on with them sometimes. Most of these things, and if you go to a kind of a site where there's you can tell it's like a therapy practice, and they've got some of these scales online, and they've they've put them up so you can self-test. Of course, they're trying to get you to come in to see them, and the truth is maybe you should go in and see them. So I don't disparage anybody for trying to coax people into their practice. I seem to not have to. I've never really had to do that. I've got I guess my specialty areas lend to people beating down my door on a pretty regular basis. So I have to turn people away, unfortunately, because of my teaching load and my research practice as well. So but there's a really good, so quality of life is really important, and sense of coherence. And there's actually a sense of the orientation to life scale, which is a really good scale that that Aaron Antonovsky put together to check for what we call burnout, literally. And so when we talk about sense of coherence, this is really important, I think, because there are 3 questions that you should ask yourself. Can I do this? How manageable is my life right now? How manageable is what I'm doing related to me, what I'm doing related to maybe taking care of our teenage children? How manageable is taking care of my ill spouse in that case? Meaningfulness is very important. Does this make sense to keep doing this way? Is there and one of the things that you think about, you get lost. One of the things I find with people, they get locked into it's almost like it's almost kind of like putting blinders on a horse. You see the, like parade horses and things like that. They can't make decisions outside of that range of limited options. I know I get that way sometimes when I feel like, when I get overwhelmed, that, I'm not able to think my way out of a situation at times. So that's where the meaningfulness piece comes into this. Comprehensibility, does it make sense for me? I should have proofread a little bit more carefully or run it through Grammarly. Does it make sense for me, us to keep doing this? In other words, how much sense does it, and that's where, of course it makes sense to keep doing this because you have to keep doing it. So that's where the helplessness comes in, and that's where you're kind of checking in with yourself constantly and having the patient manage their symptoms as well as they can, because you're going to be influenced by this just as in a number of ways, albeit differently than they are. But you're still in the fight with them in a lot of cases. So, but these 3 aspects of sense of coherence can certainly make a true difference with whether you thrive, survive, or just stay alive. That's we talk about victimization and or victimhood, and that about 20 years ago, survival from trauma became a big thing. And then now that the past few years, thriving through the trauma has become or thriving through your life experience, kind of this positive, from the whole positive psychology aspect of this, how do you thrive? So, but, and I don't think I borrowed that from anybody. I have a knack for rhymes and stuff. My family gets sick of them sometimes. So anyway, I do want to talk. This is really, and here again, the orientation to life scale is the, and I will recommend, I can send something, it's called the STARS. Aaron Antonovsky died a number of years ago, about 20 years ago, but I've actually become acquainted with his son of Avishai. He calls himself Avi Antonovsky, and he's actually in Tel Aviv, and he still carries this research on, the sense of coherence research. And so this is, yes.
Do you have 2 minutes left?
Do I have 2 minutes left?
No, you have 2 minutes left.
I do. Okay.
Yes, and I do have one question. Okay.
I'm going to leave these slides. I will talk about some of this as we go along. I do want to talk about this right quick. Yeah, I was watching my clock, Loretta, and I was thinking that I had a little bit more time than that, but okay, thank you. My clock on my computer must be a little bit slow. Anyway, so let's talk about I do want to talk about the development of the sick role and how the family has to adjust around that. the idea that you know, there are various families from a clinical standpoint. Families, we find families in a lot of these different typologies or types, if you will. One of the things you really want to shoot for as a family, and you can take a look at this is David Olson's work. One of the things you can look at is ideally these are the ideal, you know, kind of where you would really want your family to be. The mid-range here, this is not bad, but it's still, you know, it's still, there's still a lot of good aspects to these families. In terms of their interaction and their relatedness with each other. The corners over here, this is where you really get into some, and I can use really good movie examples for these. The rigidly disengaged families, if you ever saw the movie Ordinary People, these folks are ordinary. They were a rigidly disengaged families. These are very much depicted in movies where they're, you know, the family's like just really screwed up, if you, for lack of a better way of saying. Chaotically disengaged family, American Beauty, if you remember seeing that movie a number of years ago. Rigidly enmeshed families, I always used I don't remember what movie I actually used for that. A chaotically enmeshed family. I actually used to use Soul Food for that. It was a big, beautiful extended family system, and regardless of however, you know, there were a lot of different things going on in different people's lives. So there was a measure of chaos, but they were all still very close knit, regardless of the differences that they had. So you know, just keep those kinds of things in mind as well. And what to do to improve quality of life. And you'll see I'm relating back to these slides in terms of closeness and cohesion and flexibility. They'll send you these, but I can, and if you have any questions, we can communicate via email as well. Okay. And I can do Zoom too. So I'd love to, you know, I'm Zooming with people now, and I would certainly do that at no charge with any member of the Hypoparathyroid Association. So
okay, Dr. Everson.
Yes, ma'am.
We have one question, but we are going to have you back tomorrow afternoon.
Yes, we are.
For a quality of life session.
Oh yeah, that's right. Yeah. Okay.
So hopefully more people will ask questions then.
Yes, ma'am.
But we had one question since you were talking about families.
Yes.
What do you say to a child with hypopara who says, "Why can't I be normal?"
I think a lot of the way the child would cope with this would be how I don't think children, I don't see why children can't educate themselves on the condition. And it's as a and you would be talking about would be an autoimmune, or would it be a inherited type?
Oh, it didn't specify.
Okay. I'm going to save that. Yeah, that's a really tough question, and I would rather not give a half-baked answer, because I would really rather just answer the question directly and just look at it and to look at it for what it is. To tell a child why can't they be normal with hypoparathyroidism, I would need to spend a minute or two with us between the two of us, finding out what they consider to be normal. And I'm assuming they're using a frame of reference of other kids and other kids that are able to do things that they may or may not be able to. They may not be able to do that would make them certainly feel abnormal. Okay. I would hope that there was not any being picked at or any kind of bullying or anything going on with regard to the condition. Yeah, I'm gonna have to mull that one over a little bit. Can you find out if that person would be willing to have more of a dialogue with me, or that person or their parents? I'd love to chat with them. I mean, I would not like to just spend 5 minutes answering it and in a way that's only, that only fulfills part of it. So
Okay.
that's a tough question. I like that. But it's a question that nobody's ever asked me before.
Okay.
I don't. And to be honest with you, I've never dealt with anybody with hypoparathyroidism or any kind of thyroid or parathyroid disorders that's under the age of 12. That's interesting. I've had one late teen and 2 early adults, but I've never had a child. That's not part of my clinical experience. So I would love to talk with them if we could. So if they're listening, they can certainly reach out, and I would love to have that conversation
Okay,
rather than just give an off the cuff answer.
All right. So hopefully the person that asked that question, if you can reach out to us privately, we'll make sure your contact information gets to Dr. Everson so he can
Yes,
have a detailed
absolutely.
discussion with you. And we have 2 other quick questions before we
Okay.
close out. One, and I think you kind of answered it, can a person, hypopara patients and their families virtually see you with, if they have insurance coverage?
Yes, they absolutely can. And I would probably want to do the initial consultation without charge, just because I would prefer to just to get to know them, and just to find out if there's anything that there may be somebody in their area that would be better, that would better serve them. One of the things we've found one of the things I've found with doing, I haven't seen a patient live or a family live since the early part of March. So Zoom is I mean, it works. One of the things I have found is that there's the 4th or 5th session wall that we hit. They kind of run out of things to talk about, and then I find myself doing more, rather than. And I think it's the 2-dimensionality of it. So I would, if there's somebody that they could possibly see face to face, I think face to face is better, hands down, for counseling and therapy, because we really do intimately get to know those folks. I think for doctoring and physician kind of work, I think telemed's great for check-ins, those kinds of things. But I think for an hour at a time, I've got some colleagues that we do a consultation group, and that's one of the big topics that we're talking about, is how to get get deep into therapy with telemedicine or with mental health. And that's just been a struggle for a lot of, and that seems to be a common struggle when I'm looking at the boards the things that therapists are posting on the therapy boards and stuff. So.
Okay.
But yes, I'd be happy to see them, but I would probably like to do I do take, and that's the thing, in Georgia, I take Blue Cross, I take United, I take Cigna, but here again, if they've got Blue Cross, let's say from Illinois, I'm going to be out of network anyway. So I would rather just maybe consult with them, and then just try to, see if we could find somebody appropriate in their area that would be more helpful. So.
All right, and there's one final question, because we're at time.
Yes,
and
absolutely.
You may want to address this tomorrow in your quality of life session.
Yes,
how do we manage this hypopara when many of the people we need to help us manage don't fully understand, including our doctors?
Okay. All right. Manageability. That has been boy, that was like the main topic of conversation 5 or 6 years ago when I first started working with the hypoparathyroid organization. Yeah, And that goes back to what I said earlier with, I mean, well, they look fine. I mean, and, but yeah, well, you don't see what it took to get them to look that way to get out the door kind of thing, with a lot of the things that go on with hypoparathyroid patients. Let me, I would encourage that person to maybe attend. There was a really good session a few years ago that I saw, and it was a family physician. He was actually he actually had treated a number of people within the organization, I think, for hypoparathyroid, and he went through this whole thing. It was how to talk to your doctor about that, number one, and I think the doctor is a key piece to that. But and my thing, if I'm not being, I changed doctors last year, and it was a funny thing. I changed doctors last year because I felt like the doctor that I had been seeing for years had just kind of gotten complacent with my annual care. I wanted some different things, and I wanted more, more of a just run in, run out. And so I changed doctors. I found somebody else, and I absolutely think this doctor's fan, and it was a good decision on my part.
And that's been a common thread throughout. If you have to change doctors, do that. And Dr. Everson, I'm sorry, but we're at time.
Yes, ma'am.
So the last couple of questions I'm going to keep, and then make sure that they get posted tomorrow to further talk about in your quality of life session.
Absolutely, and that's going to be at 3:45. Wait now. So quickly, we're done. So let me we'll just get off. How do I get off of this thing so we can talk? Or I can.
I could do that. Once I press end, you'll be here. Yep.
Okay.
Okay. All right. Listen, thank you all for attending. I appreciate it. And I just need to ask quickly. So are we still running 15 minutes behind tomorrow?
No, we should be back on schedule.
We're back on track. Okay. And there'll be an alert if we are. Is that right? Yes. Okay. That was fantastic. That was good that Deborah sent that. I thought that was great. Okay. What time is my quality of life session?